So, shall I just give a small introduction, or maybe because I'm the speaker, somebody else could make sort of introduction, then we can start.
I think in the interest of time, you could go ahead, do the introductions, and when it comes, and as well as acknowledge guests and speakers, you do that, so that when my time comes to do that, I won't do that. That way will save time.
Okay.
Are you ready, Prof. Najib?
Yes. I think just to check that the YouTube channel is started. So we are live now. So I think we'll start. Just to. So I think let's use our cameras, all of the speakers.
Excuse me, we disable the cameras.
Yeah, just use your cameras. I think we are starting now. So, dear colleagues, it's our pleasure today, the 29th of May 2020, to welcome you in our first African webinar of the Epilepsy Alliance, African Epilepsy Alliance, which has been created more than 1 year. So I thank all the members. I thank Jacob Mugumbate from Zimbabwe. I think Chantal from Rwanda, I think, who is doing very good job, and Jacob too, and all the other members. So I thank also Professor Sanya from Nigeria, Adam Jane, Dr. Kamara, Dr. Pence Kazadi, Dr. Victor Durudamirisk, and John Jabang from Gambia, Jostas Songia, Kadviti, our president, Mbuya, Mr. Kwembo, Rabha from Libya, Rogerio Shigamba from Malawi, Tanya Spensley, she's representing the Gabin Association, she is from UK. And I thank all the organizers, and thank also the University Hospital of Marrakesh for giving us the opportunity to use the live class system of the Marrakesh University Hospital. And I think the webinar is open. Maybe Mr. Jacob could say a few words. And we will start with the first presentation, which is COVID-19 by myself.
Thank you very much, Professor Najib. I just checked the YouTube channel. We are live now, and the streaming is very clear. Thanks for organizing that. This moment is for the President to give welcome remarks. Over to you, Mr. Kadriti.
Yes, thank you, ladies and gentlemen. Firstly, may I acknowledge Dr. Najib, our host, and the Marrakesh Hospital for hosting this, the Secretary General, and the 4 Vice Presidents, and all protocol observed. I'm very pleased and happy of the progress that has been made so far to date, where quite significant strides have been made and achieved by the committee and by the alliance in general. Ladies and gentlemen, we are faced with a challenge, or a double challenge, where we have the pandemic, which is creating half of the world over, and particularly here in Africa, where we have epilepsy and the pandemic. I believe that with all the minds that we have from the 4 corners of Africa put together and coming up with strategies that will address some of these challenges, I believe this webinar will definitely help us, encourage us in terms of understanding and linking between, epilepsy and the COVID-19. However, may I also encourage all members here present to also, try to recruit more, invite more people to become part of the alliance as a continental or pan-African epilepsy organization that will strive to tell the story of the African person in terms of epilepsy and the perception that we have. And again, may I also encourage that those that are currently here try to pay our dues through, I think, the Secretary General and so forth. And also, most importantly, I would like to, on my personal behalf and the Epilepsy Zimbabwe and the Executive Committee, to thank all of you for all the good work you are doing, and sincerely hope that we will overcome some of the challenges that we currently have and those that we already have in terms of epilepsy management. And Dr. Jacob Mkumbate, thank you for all the coordination, including the Secretary General and the rest of the team. I might know by names, but I do acknowledge all your hard work. You're contributing and committing yourselves to this. And again, let's also try to support some of all our member states, our member chapters that are here in any way possible, in any way that we are able to assist them. Without much further ado, I'd like to thank you, hoping that I will be connected for the duration of this presentation. I thank you. Hello?
Yes, thank you very much, Mr. President, for your welcome remarks. We now move on to our first presentation, and this is coming from Professor Najib. Over to you, Professor Najib.
Yeah, thank you very much. I'm sharing my screen. I think now it's shared. I think you can see my screen. So thank you very much. I think all of you can see my screen.
Yes.
Yes, I can see.
So my talk is about COVID and epilepsy, so I'm happy to talk about this topic. I recognize that there is a lot of missing data up to now, and as you know that the pandemic COVID-19 started just 2 months and a half ago, 3 months. So we have some data, but we have around 27 papers published. I just did one search yesterday about the two words epilepsy and COVID-19. So I just found 27 papers, and majority have been published on April and May 2020. So that means that we have very, very few data, and we have a lot of question marks still unanswered yet about COVID and epilepsy. As you know, the world geographical situation of COVID-19 pandemic, it started in the end of March out of China, but it started in China in November and December. Then it it remained in China, but it polluted all the world, as you can see. First of all, Europe, then the United States, then all over the world. And the last country who has not been reached by corona was Lesotho inside South Africa. But just 2 weeks ago, we had the first case confirmed of COVID-19 in Lesotho. So I think every country in the world, either the small islands in the Pacific, have been contaminated. About the pathogenesis of COVID-19 and the brain. So we have very, very few reports, and the biggest one is about 261 cases. It has been reported from China. So it gave very clear evidence that there are 3 phases of the disease. So the first phase is when we are in contact with the virus, so it's viral phase. Then we have the inflammatory phase with involvement of the lung and the digestive tube, and also the brain. The brain is involved in 10 to 20% of the cases. Then the last phase is the intravascular coagulopathy, which is a vascular problem, and it's a very severe situation. So the second phase, it's inflammation and demyelinization, and it's the major phase when the brain, the central nervous system is contaminated, and we have epilepsy. We have very few epilepsy cases described, and by example, this report mentioned that they found 58 patients with involvement of the brain, and the majority of these cases were related to inflammation of the brain central nervous system. So here, as I mentioned, the three phases of the disease.
Oh, no.
As you can see, so we have the three phases of the disease. The first phase is the early infection. So it's sort of viral response phase, and it's depending on the immune response of the host. So if the person has a very good immunity, like in adults, in people without any other disease like diabetes or asthma or other infections, chronic infections, so usually the disease will stop in this phase. But if not, it will progress to the inflammatory, as you can see here. We have the host inflammatory phase. And this host inflammatory phase is very severe phase, and we have the pulmonary phase, we have also the digestive tube, and we have also the involvement of the brain central nervous system. And in this phase, when we have a lot of deaths, then it will move to the third phase, which is the vascular phase, and with high inflammation and also some vascular problems leading to stroke, for example, for the brain system, and also some hemorrhage. And also we have a lot of epilepsy cases in this second and third phase. So about the involvement of the central nervous system, it's in 25%. For example, this study published by this colleague from Iran, but he did a very good systematic review, and he found that 36.4% of the big series presented, like this Chinese cohort of 214 patients, have involvement of central nervous system. And as I mentioned, the virus involved the brain system, and we have also the involvement of the nerves. For example, when we ingest or when the virus is inspirated, so it goes through the nose, and also it involves the first nerve, which is the olfactive nerve, and its direct progression and propagation to the frontal lobe and to the central nervous system. This has been mentioned, and that's why you have a lot of anosmia in these cases. So about epilepsy, we found this very interesting study by Mao in 2020, which is a retrospective study about 214 admitted patients of coronavirus with the PCR positive. So they find, by example, more cases with involvement of central nervous system, with headaches, with dizziness, with strokes, but very, very few with epileptic seizures. So just 0.5% had epileptic seizures. And of course, these patients did not go any further investigations like MRI or EEG. This other study also, about 221 patients, so they didn't find any epilepsy case. Also, it's Chinese cohort in April 2020. There are another studies also without any epilepsy cases, and also in this one. But the report, the best report of COVID-19, the epilepsy around the world, of course, in North Africa, in Morocco, no report has been published, but I will talk about this in the coming slides. So as you can see here in this case report of these patients who had epileptic seizures, and hopefully, so it was epilepsy related, not for sure, but it was a high probability of the hypothesis that it was related to COVID-19 encephalopathy, and hopefully the patients recovered under levetiracetam. So the discussion was does this patient be at high risk of seizure? Of course, in some kind of patients, we have the acute encephalopathy due to COVID-19. We have also the multi-system organ failure, as we reported it in COVID-19. We have the lung, we have the digestive tube, we have the kidney involvement, and we have also the disseminated intravascular coagulopathy related to the disease. So all these factors are synergy factors, and they are increasing the risk of seizure, and that's why these patients should benefit from EEG monitoring. So this study has been published in May 2020. And as I mentioned, we have the inflammation in the second stage of the disease, but we have also the implication of disseminated intravascular coagulopathy related brain injury and to COVID-19 encephalopathy, as it has been reported in this study of May 2020. We have also other aspects of epilepsy and COVID, which is the use of telemedicine in epilepsy. I think in North Africa, in African islands, but for example, now we are working with the telemedicine and we are sharing our screens with our colleagues. So I think it's a very interesting point. We are using new technologies to share our experiences. So as you may see here, so I think telemedicine is a very good tool to be used not only for taking care of our patients, but also for education, for sensitization, for exchange of experiences, and we can also do a lot of things with telemedicine. Here is some MRI findings in neuro-COVID or in COVID with the involvement of the brain central nervous system with or without epilepsy. For example, in these cases published in April 2020, we see this is patient, 58 years old patient, infected with COVID-19. So he was diagnosed with brain damage and with acute necrosite hemorrhagic encephalopathy with epileptic seizures. And as you can see, we have a lot of involvement of both sides of the brain and also in posterior regions. Here you have another case published in 2020 New England Journal of Medicine with involvement also in the brain, right and left side, but also in cerebellum and also in temporal lobe. And as you can see on the right lower image, so we have the involvement of the temporal lobe and horns. So this could lead to partial complex epilepsy in these kind of patients. So this is another patient, 45 years old woman with headache and somnolence, published also in 2019, published in New England Journal of Medicine. As you may see, there is a lot of inflammation in the brain, as you can see on the pictures in the middle, the upper and also the middle and also the lower images. So we have involvement of both hemispheres and also we have involvement of the brainstem and also the temporal lobe. So we have another issue. So epilepsy could be due to the encephalopathy related to COVID-19, but we have faced many situations like some patients who have been diagnosed with COVID-19 infection has been admitted in our hospital, and we found that after taking chloroquine, so they developed some epileptic seizures. For example, we had around 9 patients that I will mention here, and we have also EEG of 1 patient. So as you know, chloroquine and hydroxychloroquine is a molecule used in malaria treatment, but it has been established as maybe with some efficacy, but just with some recent reports from WHO, the World Health Organization. So it has been established that there is toxicity of chloroquine or hydroxychloroquine, and now it's not recommended to be used in all the countries. I recognize that Morocco bought a lot of quantities of this molecule, and also I think the situation is in France, because this product is produced by Sanofi Pharma, and you have the Professor Raoul from Marseille, who is a big defender of this molecule. But now WHO is forbidding the use of this substance because in the easy and the simple cases, there is no severity and no need to use that molecule. So we collected 9 cases after receiving hydroxychloroquine. So they developed epileptic seizures, and you can see here the EEG of the last patient I saw, and you can see here some discharges, generalized discharges, very soft ones, and you can see that in such cases we can stop the hydroxychloroquine, and we can just check if there are not other side effects. And before conclusion, so I want just to highlight that epilepsy now is recognized as an expression of the involvement of the central nervous system by COVID-19 virus, by coronavirus, and a lot of reports have been established on I mentioned, but we have not only the problem of encephalopathy resulting in epilepsy, but we have also the side effects of some medication, hydroxychloroquine. And on the other hand, we have also the problem of patients are blocked at home. I think there is also a big problem of anxiety, depression, and also lack of sleep. All these factors could increase the probability of epileptic seizures. And we have also the aspect of telemedicine, which could be a very good tool to be used either for psychotherapy for these patients, for our patients with epilepsy, and also with doctors and associations to discuss all the issues. And I want to thank you and keep safe from the coronavirus, and hopefully the situation is under control, either in North Africa, but also in all Africa, I hope. And long life to our Epilepsy Alliance, African Epilepsy Alliance. Thank you very much. And we have to preserve our patients like elderly people and patients with chronic diseases who are the more fragile to this kind of disease.
Thank you very much, Professor Najib, for a well laid out presentation.
My pleasure.
Thank you very much. I'll now take this opportunity to introduce our next speaker, who's Dr. Angelina Kakoza from Uganda. Dr. Angelina Kakoza, when you are ready.
Okay.
We're going to have questions and comments at the end of all presentations.
Are you able to see my screen?
I'm not able to see your screen now. Dr. Najib, can you see?
I think we'll give you I think you can take the hand. Let me give you the right to. I think you can click on share the screen.
Where?
Right bottom lower of the screen.
Yes.
The 4 buttons. The right one is share the screen. Share.
Okay. Okay.
And click on your presentation.
Can you give rights to?
I've seen external. I see external video and add video. So
I think there is share screen.
let's share a new video. That's all.
Is that the one, Dr. Najib?
I don't see the screen of Mrs. Kakuda, but there are 4 buttons. You can just
There are
click
3. There's the upload presentation.
It's uploading. Okay. So just use your camera also, and I think it will show 2 arrows turning when it's sharing.
Professor Najib, are you able to give me rights as well as Professor Sanya, so that we prepare well?
Yeah, because it seems.
Yeah, I think Angelina, you lost.
Upload a presentation. Files here to load.
Professor Najib, are you able to share with us your screen so that we see where to click the button to share a presentation?
I think now it's Angelina who has the right to share the screen.
Okay.
I don't have the right.
No, I don't. It's very complicated. I don't know whether.
Now you have the right to share. Just now it's okay. Yes.
It's coming. It's coming now.
It's coming.
Yes.
Yes.
So just click now on PowerPoint presentation.
PowerPoint. Where is that?
Yes, it's there now.
Open your presentation and click enlarge the
I
screen.
think it's not.
I can't.
No, just go down. Open your
I
presentation.
go down. Cause
Open your PowerPoint.
yeah. So now you can see it now. I think.
So enlarge the
Yes.
screen.
Okay.
Enlarge the screen.
Enlarge.
The screen is
Yes.
okay now. I think it's large.
Yeah. So it's okay. Okay. Good.
Okay, but it's very complicated anyway. Okay, so good evening, everyone. My name, as they've mentioned, I'm Angelina Kakoza Mwesike. I'm the chair for the ILA Africa region, and I was tasked to talk about epilepsy and COVID-19 in Africa. I'd like to say that I have nothing to disclose. We see that COVID-19 is a novel viral disease and has been described as the worst pandemic of the 21st century, with over 5.5 million infections to date as of 28th of May 2020 at 6:45 CST time. And we have about over 350 deaths globally to date. The pandemic continues to advance, with Africa being the youngest continent, or the latest continent to be affected, ever since the first case was reported in February 2020 in Algeria. In Africa, we have at the moment 724 cumulative cases, with about 3,600 deaths and 50,000 recoveries. And as you can see from this graph, we can see that the COVID pandemic has been especially harsh in South Africa and in Egypt. And when you look at this map of Africa, you can see that the distribution of cases is now all over all countries of Africa, with Lesotho being the most latest entry. When you look at the risk of severe COVID-19 disease, it's been mentioned that conditions such as hypertension, diabetes, coronary disease, lung disease, and other renal or immune compromising conditions are risk factors for having COVID disease, as well as having an age which is above 50 years. Now, in Africa, as a means to curb the pandemic, a number of countries in the region have adopted several means, such as the quarantine, dusk to dawn curfews, and the lockdown system. While these are public health measures to try to curb the pandemic, the effect of epilepsy on COVID-19 and vice versa have been little explored. It's not clear what factors have facilitated or hindered the access to care of our people with epilepsy who are on chronic care management. Furthermore, we are not aware of any actions needed to strengthen the health system to meet their needs during this time. Reports from the CDC indicate that epilepsy may be a risk factor, especially for those who smoke, those who are obese, those who have diabetes, those who have cancer, those who have lung disease, and those who have heart disease. Now, is the SARS-CoV-2, that's the one that causes COVID-19, neurotropic? Based on the results of what has been found, the angiotensin II receptor has been found in glial cells and neurons. And it's postulated that because of this, it's possible that this virus may be neurotropic, but the results from studies have not confirmed this. And there's still a lot of gray areas regarding this issue. And what we see now is there's a lot of fog regarding COVID-19 and epilepsy. Several case reports, several case studies, but there's not been a really coherent study to come out with what exactly is the association between COVID-19 and epilepsy, resulting in a war in terms of what exactly is happening is not yet clear. So what are some of these challenges? Looking at this presentation, at the place where I work in Uganda, you can look at the attendance of patients from February up to May 2020. You can look at week 1, week 2, week 3, and week 4. Now, our lockdown began on March the 19th, 2020, and that was in week 4. You can see the reduction in attendance of the number of patients. And currently, as we talk, the number of patients are not as high as they were in February. What does this mean? We have patient-related challenges, reduced utilization of healthcare services due to transport restrictions, or unwillingness to seek care for health conditions that are perceived as not urgent, or fear of harm from security forces exercising enforcement by violence. So these patients also tend to isolate themselves for fear of contracting infection from hospitals and clinics, raising their stress levels and the risk for seizures. Furthermore, the information sourced from the internet and social media can be sensational or misleading, resulting in people with epilepsy responding erroneously or panicking unnecessarily. In addition, there is increased incidence of mental health conditions such as depression and anxiety due to, amongst others, social isolation and anxiety associated with uncertainty and worry. This interrupts their routine medication refills, unmasking seizures in the setting of exposure to the virus, and of course resulting in an increased risk of seizures. This increased risk of seizures can result in status epilepticus, with all the related complications including injuries, hospital admissions, and potentially sudden unexpected death in people with epilepsy. The caregiver-related challenges revolve around battling with a feeling of being overwhelmed, and also feeling guilty that they're not able to take care of their person with epilepsy. They're stressed by the schedule changes resulting from the pandemic, and this scenario negatively impacts their employment, home life, and mental health. And furthermore, these caregivers who may be infected or suspected to be infected with COVID will stop providing care to their patients by isolating themselves, leaving their dependent patients at risk of poor management. Clinician-related challenges are also present. Some clinicians have absconded from duty due to fear of getting infected from their patients, especially those where there are limited cases of personal protective equipment, and also those in the senior age bracket. There's lack of awareness of some potential treatments that may have drug-drug interactions with antiepileptic drugs, necessitating dose adjustments with antiepileptic drugs and COVID treatment. Health system challenges are focused on governments and ministries. We know that there's been a lot of hype regarding COVID-19 with minimal consideration of other services, especially like for those with chronic care like epilepsy. And this focus of COVID-19 may overshadow the treatment required by other chronic conditions such as epilepsy, increasing the risk of complications in these individuals. Furthermore, the health system is not adequately prepared. Majority of our health systems are very weak and cannot deal with the massive rise in the number of infected cases, let alone with the consequences of lockdown. So, what does this mean in terms of our opportunities with COVID-19 and epilepsy? We need to utilize reliable information. A system for disseminating reliable resources has been established. Translations and subsequent dissemination of these resources are available and can also be accessed by epilepsy patients globally. This will help in reducing unnecessary anxiety and stress. Amongst these avenues is the ILE website, which has been set up by the ILE COVID-19 Task Force, which can be accessed by everyone. And these are sort of the information that you can get on research, on case reports, surveys that you can use for your patients, resources for webinars and educational resources. In addition, WHO has also helped to counter disinformation by guiding countries on setting up call centers to ensure that the public is informed, and these updates are regularly done on the World Health Organization website. Furthermore, we have an opportunity of leveraging technology. We need to explore innovative models of care, such as telemedicine, to enhance continuity of care with people with epilepsy. Also using of the telephone for consultation interviews where possible. But remember that there is a risk of digital technologies enhancing inequalities of health care, especially for the rural poor or those unable to access such facilities. We also have an opportunity to mobilize community health workers by providing medication refills for those unable to access health service. But there's a risk here because we are violating the social distancing rules and increasing the risk of transmission. This can be mitigated by providing personal protective equipment and ensuring hand hygiene is observed during the household visits. We also have an opportunity of facilitating the work of medical workers at the front line. Continuous medical education, like we are doing through webinar seminars, sharing updated information amongst ourselves, conducting research on patients with epilepsy and COVID and vice versa, and also having the governments permit our movements where lockdowns, curfews, and movement restrictions have been imposed. So in conclusion, while COVID continues to spread across the globe, the public health strategies to curb the pandemic may affect our patients with epilepsy. The effect of COVID on individuals with epilepsy and vice versa remains unclear. Clinicians need to share case information, continue investigations, provide known facts to epilepsy patients and their families. And we also need to utilize reliable sources of information on COVID-19 and epilepsy as much as possible. Thank you very much for listening. I would invite any questions later on.
Thank you very much, Dr. Kakoza, for a beautiful presentation. In the interest of time, I'm going to suggest that I skip my presentation. I will share with you the slides and also present in our next webinar. We are only left with a few minutes. We might be able to extend a little bit, but it would be good if we hear from Professor Sanya from Nigeria. Professor Sanya, would you want to present now? I can't see. Yes. Professor Sanya, you are muted.
Thank you.
Thank you,
Okay.
Professor Sanya. Please go ahead with your presentation. Are you able to share your screen?
Can we see?
Not yet.
Not yet. Wow.
It takes few seconds.
What about now?
Not yet.
Slides. What should I do then? Share your slide. Share.
Yes.
It's not. Why is it not entire? Entire slide.
Yes, it's not yet there. Professor Najib, you shared.
I've asked you to share.
You gave Professor Sanya the rights. Did you?
I have asked you to share, but it's not giving me the icon.
I think he already has the right to share. Just
Okay.
to put 2 arrows turning.
What?
Take 2 seconds. Click on sharing the screen.
I have already clicked on it.
So it takes a few seconds. You will see 2 arrows turning around.
Not yet.
So just click again.
No 2 arrows are showing.
When you click on share screen, click inside the screen. Then it says,
Professor Kasani, can I be directed how to get out of this. Maybe it's because I'm not out of the screen, that's why he can't.
No, I think he has the right.
He has it right now, okay.
Yeah. Whenever
the
side will disappear.
only thing I can see is your entire screen, application window, Chrome tab, but he's never, I've said he should share, nothing's coming.
Just click on the screen, then go inside the screen, share.
I've clicked on it. Okay. What about now?
Yes, now
Yes, it's coming now.
Can you see?
Share.
How about now?
It's okay. So
Yeah,
it's
very
okay.
set.
Go on.
You
Go
can
ahead.
see?
Yes.
Yes.
So I can continue? Okay.
Yes.
So COVID-19 charting a course for epilepsy in Africa. I must confess that some of the things I'm going to talk about, some have been previously mentioned like you expected, but I'll just move. The world has been gripped by the outbreak of corona infections since December 2019, which initially was first reported from Wuhan. The virus has high affinity and attached to the angiotensin converting enzyme 2 receptor, which is on cell membrane. And once it gets entrance into the cell, we could see that it enters into the cell. The brain, like other tissue, expresses these ACE2 receptors via its glia cells and neurons, as well as the capillary endothelium. Like it was other speakers have mentioned, thus the neurons and the nervous system is a potential target for this virus. Some study have shown that CSF in patients contains the viral, as well as autopsy has shown that the presence of the virus in neurons of that patient. The virus can get access into humans, human brain, basically either from viremia via the blood circulation, or like earlier mentioned, through the cribriform plates via the cranial nerve 1, olfactory nerve. And when the virus gets into the neurons, it causes neuronal inflammation and ultimately cell death. For now, evidence are just emerging, but it's not yet conclusive that people with epilepsy are more likely to get COVID infection than anyone else without epilepsy. However, it is there is a plausible evidence that the virus through encephalopathy can cause acute seizures, as well as from medication used to treat the virus. But it is too early for anybody to talk about the virus being epileptogenic later in life. So we cannot talk of epileptogenesis now, but all we can see is that the virus causes acute seizure from several mechanisms. However, persons living with epilepsy with diabetic, like everyone has said, hypertension and asthma, that has problem with the angiotensin converting enzyme pathway. Because we know that what the virus does is that once the virus enters into the cell, what it does, it blocks the angiotensin 2, leading to increase in angiotensin 1. And angiotensin 1, we know once it causes inflammation of the cytokines, specifically interleukins and cytokines will lead to hyperacute inflammation. So people with diabetes, hypertension, and asthma that have aberration or change in the angiotensin receptor pathway have been found that is why they are likely to have increased morbidity. Persons with epilepsy that have COVID may have more seizures, so because of encephalopathy or fever or even antiretroviral drugs. So we can see that COVID can have asked in 2 ways, can increase acute seizure. And in persons with epilepsy who now have a co-infection, COVID can exacerbate repeated seizures or reduce control. Anti-seizure medication also, especially those that affect that are inducers of cytochrome P450, can increase metabolism and some of these antiretroviral drugs. And therefore, antiretroviral agents also can affect anti-seizure medication. All this can affect the balance of seizure control. Now, in our own continent, the influence of COVID on our continent, in the society, COVID has helped to amplify challenges of epileptic care in Africa, which can be biomedical, psychological, psychosocial, or even economical. Like a lot of us have mentioned, there are now anxiety, social problems that we have not controlled, even economic problem. COVID pandemic has amplified it since we were not prepared for it. The lockdown also has led to widespread poverty and increase in social vices. While there's also worsening of psychosocial barriers to epilepsy, all the previous psychosocial issues with epilepsy have also been worsened by COVID. Stigma, negative attitudes, stereotyping, the presence of COVID has amplified all of them. On individuals with epilepsy, COVID has now led to secondary treatment gap widening, because somebody who had been on drug before, with cessation of anti-seizure drug, has moved into secondary treatment gap group. And so he stops the medication because of either he cannot lay hands on the drug, there's a job loss, so there's no money to procure the medication, or the patient is frustrated, there's poverty. Now, because people are locked down at home, the contact with the husband and wife, contact with the family has exacerbated marital disharmony, and there's also reduced financial power. So all these, we have influence of a person with epilepsy. Stress, anxiety also have increased in the effect of COVID pandemic in the region. Then we also must look at the Chinese special epilepsy group: women with epilepsy, children with epilepsy, elderly people with epilepsy. The lockdown due to COVID increased the number of women with epilepsy who are likely to become pregnant. There will be contraceptive failure or even teratogenesis. And also, because hospitals are shut down, we have a challenge with management of epilepsy in pregnancy and even problem with delivery. So more of our epilepsy patients now will have to be delivered by traditional birth attendants, since most hospitals are now shut down. So we have a challenge we must look at here. In children with epilepsy, their school an educational system will be challenged. Skills acquisition, where they have been learning skill, are shut down. Elderly people with epilepsy, there's a fear, since we know that epilepsy and COVID is more in the elderly. Presence of comorbidity, all these have increased risk and of increased poor seizure control in this group of patients, which we need to look at in this meeting to discuss. Now, what are the ways we can chart a course for a patient? One, we must emphasize they must never stop their drug during this COVID pandemic. Two, our patients should avoid visiting hospital or emergency department, because we know that hospital healthcare worker now can transmit this illness, this COVID infection. Three, we are to advise our patient on healthy living, and they are to avoid seizure precipitating factors. So they must sleep well. They must start as much as possible to avoid anxiety and anything that will make seizure control less likely. Then 4, routine EEG and other investigations should not be done with pandemic now. So as much as possible, we should encourage our patient, we should encourage the healthcare worker to stop asking our patient to go for EEG in the hospital or other investigation until when the hospital is much safer to attend. Then, as healthcare provider, we need to now provide good and adequate information. Somebody has said that the social media is now a means of selling fear and anxiety. So we must take it on ourselves to provide information in major languages and dialects, the radio stations and television in Africa, especially in the rural areas, providing the right and correct information. Then, what a person with epilepsy that now have a breakthrough seizure? We are to encourage use of phone calls to healthcare workers and doctors on what to do and how we can help them have their seizure controlled. And there's need for us to provide an African-based study and case study and multi-center studies so that we can look at what is peculiar in epilepsy in Africa. Professor Najib was talking about hydroxychloroquine and chloroquine in COVID. There's a lot of politics in it. If you read what came out of Lancet just yesterday, you will realize that there is politics in use of hydroxychloroquine. And a use of hydroxychloroquine must be started before in phase 1, not when it gets to phase 2 or phase 3. If you use hydroxychloroquine in phase 2 or phase 3, you are going to get other untoward side effects. So we need to know much about it. We need to educate ourselves just like we're doing now. So other way we need to chart costs for epilepsy in Africa, we must create alternative medicine for patients for their drug refill, either home delivery or through phone calls like has been mentioned. We can look at home delivery if pharmacies or other courier services can help to deliver drug for a patient and they come into the hospital. Then we have to discourage panic buying and stockpiling of pills, especially for low-income earners. So once that drug is exhausted, they should refill rather than panic buying, so that because panic buying and stock filling will make the drug unavailable for others. For health workers, what do? Capacity building, just like we're doing now, via internet, WhatsApp, social medias, will help to create good and adequate information that will help in early diagnosis of new cases for those in rural area, and also help in uninterrupted drug supply. To have the use of various appropriate technologies, text messages, home cell phone, social media, and WhatsApp group. In conclusion, COVID pandemic has influenced epilepsy care in our continent. There's no convincing evidence now that COVID not seizure now can cause epilepsy, not seizure. People with epilepsy with other comorbid conditions may be more susceptible to have COVID infection. And people with epilepsy should avoid visit to hospital for now. Contact details of healthcare provider in each regions of Africa should be made available to our patients so that they can call us on phone calls or even email us when they need us, when they're in challenges, so that we can drive them as at purpose. And as more information avail us on COVID, we will continue to improve on epilepsy care. So there's still much we need to know, and I see yet we can do for COVID, our epilepsy patient in COVID pandemic. Thank you. God bless.
Thank you, Mercy. I want to ask participants to prepare to ask questions and to make comments. Others are using the chat panel, which is okay. But now we've got an opportunity to ask questions and have them answered by our speakers, Professor Najib, Dr. Angelina Kakoza, as well as Professor Sanya, who just finished his presentation. Thanks, our speakers, again for all the beautiful presentations. Now we open the discussion. Let's have questions from participants. If you're about to speak, make sure your mic is turned on so that we can hear you. Then afterwards, turn it off so that we avoid some noises that we're hearing.
Yeah, thank you very much, Mr. Jacob. Thank you. So I ask all the speakers to use their podcasts to see our pictures. And I want to ask Professor Sanya about how many cases of neuro-COVID have been collected in Nigeria, and maybe how many epilepsy cases with epilepsy, maybe in hospital or in
as of today, in my hospital, only one patient, only one or two in the whole country that have had reported seizure, acute seizure. Otherwise, seizure is not a major means of manifestation in our country. Most of the time, most of the manifestations are respiratory. Acute seizure is only one or two patients that have been documented.
Okay. In our experience, we have around, because in Morocco the total cases is around 7,400, and with these cases, I can talk just about Marrakesh. We have around 15 cases with neurological manifestations. It ranges from agitation, from hallucinations, from epilepsy, as I mentioned, in 3 cases. We have 9 in all Morocco, but we have also some brain abnormalities on the MRI, but without any clinical manifestations. So I think I got one question from Dr. Clavor, who is from Ghana, training in our department, asking about any sequels in the future when, for example, you have patients not suffering from epilepsy, but if he has any risk of developing epilepsy, for example, in the coming months or coming years. But I think we cannot respond because, as you know, COVID-19 is new, and in the coming months, if we can see cases with epilepsy, then if we can come back to their history to demonstrate that they have been infected by COVID-19, by coronavirus, and they had some abnormalities, as I mentioned, on the temporal lobe or in other parts of the brain. In these situations, we can maybe have this or any other markers. It will be difficult to answer.
May I come in? Hello?
Yeah.
You see, it's been shown that COVID is associated with occlusion, intravascular coagulopathy, and ischemic strokes, especially small vessels and medium vessels. And so and you know that one of the common causes of epilepsy is stroke. So now that we begin to see reported cases of both MRI and clinical manifestation of ischemic strokes, it's just a matter of time. Let's wait. Let's start a longitudinal study and look at them. We know epileptogenesis is for a few weeks to months or years, but the likelihood that COVID may result in epilepsy is there. But it will take a long time for epileptogenesis to take its full course. But we know that since COVID can cause ischemic stroke that has been reported, then the chances that it may result in epilepsy later in life cannot be. It is plausible that it can result in epilepsy later, but what we know now is a common cause of acute seizures. Thank you.
Yeah.
Just to comment on that as well, there has not really been there's no available data to suggest that people with epilepsy are more likely to be infected or have even more severe COVID disease. There have been thoughts like patients with tuberous sclerosis complex who may have reduced lung function and being treated with immune therapy, they may be at great risk. But these are still being observed. There's nothing at the moment. And overall, there are no reports of either worsening conditions in patients who have been exposed to COVID regarding epilepsy.
Yeah. I think
Thank you very much. Can we hear from the other participants, their questions?
Yeah, I think we can also read on YouTube and also on the chat here. We can ask questions as people are asking on YouTube. I suggest why not to do sort of collection of all the data from our countries, from Nigeria, from Morocco, from Zimbabwe, from Uganda. For example, all the cases with the clinical manifestations in our main hospital. That will be very interesting study presented by our alliance. With some EEGs and MRIs, and because I think, as I mentioned, there are very few reports on the literature. Just 27 when you put epilepsy and COVID up. Since yesterday, I think there are no more than 27 reports, and not all of them are talking about epilepsy. And are talking about telemedicine, about sleep, and the effect of lack of sleep, of stress, and other points.
Thank you very much for that. I checked on YouTube. There are no questions at the moment. There are only comments.
Okay.
But we might have members with questions. Please feel very free to ask your questions about COVID and epilepsy.
I think, Mr. Jacob, you asked me maybe, is there any live telemedicine group up and running currently to share the info? I think we have the group of telemedicine, but I think we'll share it later. But all of them, they have the YouTube channel.
Oh, okay, so you are referring to the question about the telemed group. Would you want to provide more information for those who would want to join this group?
There is.
Yeah, about telemedicine, I think we have a very active group, so I want to congratulate all the members, Jacob, Chantal, but all the other members. I think we are doing a very good job. We have the WhatsApp group. We just created the website of the Alliance just 2 days ago, and I think you can find all kind of informations of the activity of the Alliance on the website. I think we can share it maybe later, or we can just give you the link. And I think we can also put such presentations on that website, and also in the gallery, we can put all kind of pictures or videos just to let people check and see people who did not attend.
Okay, thank you. Thank
Jacob,
you very much.
there is a question. There's a question that I read on the chat of a certain Michael who's asking, what program is there to manage stress? Michael from South Africa. What I can say is that we need to have comprehensive care plans for our patients, emphasize that adherence to daily routines and being consistent on that is maintained. We should prevent medication shortages by maybe ensuring longer prescription refill plans, having access to telephone advice for those who suffer from mental health issues, adequate sleep, engaging in routine exercise, eating healthy, and avoiding alcohol and recreation drugs could be some of the ways to reduce some stress.
Thank you very much. I saw the question. Thanks, Mike from South Africa. Any other questions, colleagues? We are about to end the meeting. It's 4 minutes past our time, but we can still take some questions. Any questions, colleagues? So I'm wondering if, yes, please go ahead.
Yeah, it's Tanya. Thank you everyone for great presentation. I'm having trouble with the public chat. I can't seem to enter any messages, but yeah, I mean, we've had great problems in the United Kingdom with the coronavirus, and they're all telling everyone to be self-isolating and, you know, keep drinking lots of water to prevent the disease and distancing yourself from people 2 meters. And I've been working from home since mid-March. You know, it's you know, it's been quite a challenge. We haven't had epilepsy as actually been diagnosed as one of the high risk categories. You know, you've had ones like asthma, cancer patients, diabetic patients as high risk, but they haven't classified epilepsy as a high risk category. Do you think it should have been?
Good question. Thank you, Tanya. So any response from any of the speakers or any of the participants?
Well, my own contribution is that we should try as much as possible to avoid stress, because we know that COVID pandemic has changed a lot of our routine activities. In fact, the lockdown itself is stressful. When you are just at home, you are doing nothing. And like I said, a lot of people who either are now stressed, we take up anyone near beside them. We take up the anger, the stress on people around them. So we should try as much as possible to do things that we read books, do more walking about, television, reading novels, drinking water. All this will help to allay anxiety. And we should desist from visiting websites that are going to put us more into danger. If you're not a clinician, desist from visiting sites that are only meant for clinicians. All this will help us to so as much people we don't stress ourselves. There are gamuts of information now that can even put even the clinician themselves into stress. So all of us in a time like this, we have never passed through such a situation. We should try as much as possible to get close to loved ones and that can share issues that are bothering us with. Thank you.
Yeah. Well, I've kept in touch with all the people that I know in Gambia as well, and been keeping them informed, just of, you know, keeping hydrated and keeping distancing from other people and general safety. But I'm not a doctor. I'm a Gambia Epilepsy Association, so I can't give medical advice. But I'll do the best I can.
Thank you so much, Tanya, for your question, and thank you, Dr. Professor Sanya, for your response. I've got a question. What research is happening on the continent in relation to COVID and epilepsy, if there is? If there isn't, what could we do to increase research around this new area?
Can I come in?
Yes, please, Professor.
Yeah, well, I must tell you one problem we have in Africa. People have made politics out of COVID.
Mm-hmm.
I was in a meeting yesterday. Most African countries are setting up centers, isolation centers.
Mm-hmm.
And these isolation centers are barriers to people doing good and clean clinical research. Once somebody is positive for COVID, is sent to an isolation center. And you know, isolation center is not a place for every clinician to enter. So that in itself is a barrier for us having all the details and follow-up information of patients, because politicians have taken over COVID to score cheap political gain. But as much as possible, what we need to do is issues that we can look at is, for now, acute stress during COVID, post-COVID, and longitudinal studies, that even once they come out of isolation center, we can follow them up and see the sequelae that can, because people, I mean, you must know that COVID can be associated with fibrosis, and fibrosis can affect the lungs, can affect the brain, can affect different tissues of the body. So even if we cannot catch them, we can't do much during the acute, because if they were managed in hospital, like it obtains in Europe, it will have been easy for you to do MRI and all those things. But creation of isolation centers is a big problem that I see that will impact us having good clinical data on COVID in the continent. I'm yet to be corrected.
I think, if I can add, I think we have to separate between patients with epilepsy with COVID infection and patients or normal people. I think, are they exposed or not to have seizures? I think for patients with epilepsy, of course, I think, as you mentioned, stress, we have also lack of sleep, we have a lot of factors. But as I mentioned, we have also the hydroxychloroquine. I think we have many patients now reported, and we have also few papers. I think, as I mentioned before, it's time who will respond to the causality between this medication and the epilepsy. But I think for patients with epilepsy, I think there are a lot of other factors. And I think that's why, as Professor Sanya said, we have to avoid for these people to get in touch or to get at risk of being contaminated by the virus. So I think it's better to keep out of the hospital and to take all the distanciation measures.
Professor Najib, I have a question for you.
Yeah.
You see, I personally don't believe, you know, chloroquine have been used for years in Africa. Chloroquine. Yeah. And before the advent of COVID and US president making noise about it, nobody talks about COVID. I mean, hydroxychloroquine having much problem. Almost all in Africa, we have been using chloroquine for donkey years. And so why are people now coming out to make noise on hydroxychloroquine? In my country, almost all the patients with COVID were treated with hydroxychloroquine, and the outcome was a success. So Nigeria, we don't believe in what they're talking about hydroxychloroquine and chloroquine. I think it's more of politics. If you look, go and read Lancet, and New England Journal came out today, all about more than 400 professors condemned the WHO reports on COVID, that it is political. it's published in New England Journal of Medicine that the WHO report on hydroxychloroquine is not totally correct, that the statistics is wrong. So we are here to come clean with hydroxychloroquine. Chloroquine has been used for the whole of Africa for donkey years. So I think it has been politicized. And we scientists, we just keep quiet and watch them as things unfold. Thank you.
Yeah. So I agree with you. Just if you allow me, Jacob. So I think Mr. Sanya is a defender of chloroquine. But I'm not saying bad things about chloroquine, but I just want to say that maybe the data that we have, it's very early to take any conclusion. Maybe I think we can talk about this maybe in 4 or in 6 months or in 1 year,
yes,
just to say if it's bad or good medication. But I fully agree with you that it's a lot of politics because it's very cheap medication. And lots of people now, they want to buy a lot of pharma from the United States, from Germany. They want to buy their products, which is very expensive. So I think if we have chloroquine with these products, I think that will imbalance for chloroquine.
Thank you very much, Professor Najib, for the discussion. In the afternoon, we had a WhatsApp discussion with members of Epilepsy Alliance Africa, and there's a question that came that I think maybe it relates to what we are talking about, and we might want to discuss it briefly. The question was about use of herbal medicines, use of COVID organics and related medications. What's your view on those issues? Any advice around that? It's a question that came from one of the members of our group. Any ideas around that, even from the participants? Perhaps we could leave that for next time. There's also one last question from Inyama here. How can we African countries make some multi-country studies on COVID-19? Any response to that?
Yes, I think I can respond because I'm encouraging research and all the activities, collaboration activities in Africa. And we already started many collaborative works. So I think, as I suggested before, I wonder if we can create some subgroups of thinking in research in Africa. I think we can, for example, make one group of infections, another one of social aspects of epilepsy, another one of statistical data about epilepsy and about number of neurologists, and another one about surgery of epilepsy. I think we can do a lot of things. And I think, Occidental world, they will respect us when we will publish reports and publications, including just our collaboration without involvement or any people from Europe or United States.
Thank you, Professor Najib. I agree with you in terms of us doing something on our own, writing and publishing. That's very important. I want to ask all participants to turn on their video so that we say goodbye to each other. Others have not turned on their videos.
I thank you and keep in touch, and good success to the Alliance, African Alliance, and lots of collaboration.
Bye.
Yes, can I check if Shandeo is in so that you give your closing remarks? Shandeo is the Secretary General of the Epilepsy Alliance. Shandeo, you are locked. And Professor Najib, how do I see everyone so that I take a screenshot?
Yeah, just go to the click on the users on the left. We have 19 users now.
The users on the left, yeah?
Yeah. Here we have Chantal and
no, it's
users
not showing
only
it's not showing everyone.
YouTube. Yeah. But on YouTube, I think we need to ask our webmaster who will give us the data later.
More people on my screen.
Angelina, how are you?
People on my screen.
I think also we are very happy to have this opportunity to share our things that we can offer. For example, the live class system we have in the hospital here, and all our Yeah.
Other people have not put their video on.
Follow
I'm
you.
only.
I will take
Can
some
we all put
screen-
our videos on? I've got 9 people out of 19. 10 people have not put their videos on. I want to take a screenshot.
Yeah, we are 10. I think we need the other members to join.
Tanya, I can't see you.
I know,
Michael.
it stopped working. It's been on too long. It's, oh,
Professor Sanya, good to see you.
No, my brother, how are you?
I'm good. I'm good.
It's raining.
Angelina,
It's
good to see you
raining
too.
here.
What did you say?
It's raining cat and dog in Nigeria, in my states. Yeah, raining.
Oh, really? Is it raining?
Yeah.
What happened?
Ask God.
Okay, other people have not turned on their videos. Maybe they are having challenges, but I've taken a screenshot. I will share with you. Chandel, are you online? Dr. Najibi, do you want to give closing remarks so that we close the meeting?
Yes, so thank you very much.
Can't hear me.
Yeah, thank you very much to all of you. Thank you to all the members of the Alliance. I think together we can do lots of things for Africa and we can support. And as I shared with you, the project of how telemedicine could help Africa, I think we have some opportunities to find the finance and the funding for some such projects. So I think we can collaborate together and show that we'll reach, that we'll find funder for our projects, and also our website. We can put all information on the website. Thank you to all of you, all the speakers and all the attendees by YouTube and all the channels.
Thank you, Professor Najib. Thank you, everyone. Hope to see you again next month. We have arranged webinars each and every month until December. I'll say goodbye now. Goodbye, everyone.
Cheers. Bye.
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 Bye.